Welcome to Leadership Chats with Dr. Wise, the Not a Lecture podcast where we explore what it really means to lead in today's complex healthcare environment. I'm Dr. Wise, and in this series, we're having real conversations about essential leadership concepts. We'll talk about what you need to know, what you want to know, and what you'll actually use in practice. And yes, what you need to know to pass the exam. Each episode, I'll be joined by a guest expert who brings real-world experience and insight into nursing leadership, from managing care teams to fostering a culture of safety and everything in between. Whether you're listening on the go or settling in with your notes, this is your chance to deepen your understanding and connect what you're learning to real-world practice. No slides, no lectures, just meaningful conversations that bring leadership to life. All right, today I have the privilege of sitting down with someone who truly understands and has lived and breathed quality improvement. I have Dr. Barbara Cherry with us today. We're going to talk about quality improvement, what it really means in practice, how nurses play a central role with it, and how you, even as a student or a new graduate nurse, can contribute to both a culture of safety and continuous improvement. So, Dr. Cherry, thank you so much for being with us today. To get it started, why don't you share with us a little bit about your background and how you became involved in quality improvement work?
Okay, well, I have been a nurse for 51 years. I went to nursing school right out of high school, got my diploma, and then did the whole bachelor's, master's, doctoral journey. But it was actually in my first role as a nurse. I had been out of nursing school probably 10 years. And the company I worked for, it was hemodialysis. It was a fairly new practice of nursing, nephrology nursing at that time. And they got into quality improvement. And so I didn't know anything about it. We didn't even have anything in nursing school about quality improvement because it wasn't a thing for healthcare back in the 70s and 80s and even into the 90s. As your book points out, when the To Err is Human came out in 2000, that identified all the errors that occur in healthcare systems, that is when QI really took off in healthcare. But fortunately, I was exposed to it before that, like about in the late 80s. We had to do for our dialysis patients, we did a lot of quality improvement initiatives around reducing hospitalizations. What did we need to do to keep these people out of the hospital? Because it's like we were always sending them to the emergency room for something. And I figured out when I got smarter, it was great for the patients because they did not want to go to the hospital and they were healthier when we kept them out of the hospital. But it was actually a financial issue for the company that I worked for, because if the patient wasn't in the chair getting dialysis, we couldn't bill. And so, although it was very good for the patients to keep them out of the hospital, it was also very good financially for the company. But that was my first exposure to QI, and I really I did my thesis for my master's program based on quality improvement. So I've used it ever since the late 80s, actually. So it's a great concept.
That's awesome. So you have some extensive experience in that area.
Yes.
So very cool. Well, I appreciate that you're here with us and that we can leverage this expertise and experience, and especially the fact that you've been involved with quality improvement really kind of since its inception as something that we focus on, I guess, in the healthcare world, but specifically to nursing. So it's a really big part of our practice. So awesome. Well, let's start off by laying the foundation and really just defining what quality improvement in nursing practice is. So for students who are being introduced to that, I mean, everybody is probably going to have a different level of understanding based on their experience or assumptions of what it might mean. We can interpret that to be a lot of things. So why don't we have level ground here by having you describe what quality improvement is in nursing and why does it matter?
Okay. So I know you'll read several definitions in your textbook and your ATI content and all the Pearson stuff about the definition of quality improvement. But what it really means, the bottom line is that we identify problems as nurses, we see issues, and we say we need to make this better for our patients, for our staff, whether it's nurse turnover, it might be you see problems, your patients are always upset because their discharge process takes so long.
Hmm.
Those are the perfect opportunities for to say we need to improve this problem. Our discharge process is a problem. Patients are going home upset because it takes much longer than they anticipate. So, how can we improve the process and improve our patients' perception of the hospital when they leave so
Hmm.
they're not feeling upset about their discharge process? So, really, anything, medication errors, quality improvement is exactly what it means. We want to improve exactly what it says. I'm sorry. We want
Right,
to
right.
improve the quality of all of our services, everything we do, whether it's for patients, and it also applies to our work settings.
Hmm.
So, how do we improve the work environment for nurses by looking at quality improvements?
Awesome. Very good. I think that's a really comprehensive look. I mean, because it does apply in so many different ways, but it is exactly what it sounds. Let's improve the quality
Right.
depending on which category we're looking at. Great. So I think it's important to emphasize that quality improvement is a continuous process. So it's not just we pick a project and do it one time and then move on. It's going to have different iterations to it. We're going to repeat it. It's going to grow and develop. So, can you give us an example from your experience that shows what that ongoing process looks like in the real world nursing approach?
Absolutely. It's kind of hard to think about which example I want to use, but one of them that I think is really good and kind of represents the long-term process of quality improvement is a project I worked on for about 2 years, reducing the wait times. I'm sorry, reducing left without being seen
Hmm.
in the emergency department.
Oh,
So,
yeah.
um, so what happens when patients come to the emergency room? If it's really crowded, it's a really bad day in the ED. They're overwhelmed. Not enough nurses. It's just an overwhelmingly busy day. Patients will check in, they'll wait, and then they eventually leave without being seen. And
Hmm.
you can think about all the consequences that may have for the patients because they're not getting the care they need. Maybe they're going to go to another hospital. The hospital's lost that patient. So there's lots of consequences from left without being seen. So
Hmm.
in one particular emergency room, they were having a huge problem with patients they call it left without being seen. And we embarked on a project to improve that. And it took the entire team. So we had to sit down with all the ED nurses and also the providers, the
Hmm.
physicians. They had to be part of it because we had to map out our processes. What happens when a patient checks in? How are they triaged? Where do they go? How do we start care much quicker so that care's in process and they're not walking out the door and leaving without treatment? And we don't let somebody that really has something very serious leave and then get into some horrific medical crisis because they didn't
Right.
get seen in our emergency room. So, but it actually took, we tracked numbers, we implemented a new process, we tracked numbers of left without being seen, and for a while it didn't change a lot. We
Hmm.
realized we needed to do a lot of education for the nurses because the nurses didn't understand the new workflow that we designed to reduce the left without being seen. Also, then the providers, once the nurses were getting the patients ready quicker, triaged and ready to see a provider, the providers weren't there. They weren't able to get in to see the patients. So
Hmm.
that was another hurdle that we had to work with the providers to overcome. And another one was the EHR. So there's always going to be a technology piece with quality improvement. So we had to work, how do they access, how does a provider get quick access to what has been done with this patient that's in the EHR, the electronic
Hmm.
health record. Um, and so it actually took probably 18 months. And then we really did see a tremendous drop in our left without being seen.
Mm-hmm.
But we were always meeting, always going back to the drawing board. We said, this didn't work. Let's try this. We need to involve, um, pharmacy. We need to involve lab. We need to involve the physicians. So it wasn't just nursing couldn't just fix this problem.
Mm-hmm.
And that's why it was a long-term thing, but we didn't give up. We kept tracking. And to this day, they're still at that ED. They are still tracking. They're left without being seen. So,
That's awesome.
yeah, it is most processes that you do with quality improvement, you're not going to fix in one little cycle of improvement.
Mm-hmm.
It's going to take a repeated process, and it's also going to take involvement of more of the disciplines, more people, more departments in the hospital or wherever you are. If you're
Right.
a public health agency, a clinic, whatever. So it's a very much a team effort.
Yeah. I love there's so many different things that you added or points that I pull out of your experience. You highlighted some of them. It took a while. I mean, it took 18 months, 2 years ish for you guys to make that change. Plus, um, the involvement of the interdisciplinary team. I mean, that's a huge point that it's not just within nursing. Nursing might lead and drive the quality improvement, but we have to work with the whole team to make it happen effectively. And it was multi-layered. I mean, you start with one idea. There's evidence to support why you go with that idea, implement an approach to try to influence the change, and then reevaluate and start over again. Kind of, I think about it's like the nursing, the nursing process in itself, but
It
it's
is.
that
It's actually very similar.
right assessment, evaluation, or excuse me, assessment, implementation, evaluation, repeat, and over time, it just became more and more fine tuned to make the adjustments you need. So I think that is a great example. So
If I can say one more thing
yeah,
about that,
please
because I
do.
forgot, this gives the systems perspective on quality
Yes.
improvement. The other thing we had to involve, we had at some point we realized the whole hospital has to be involved because there was an issue with backup in the ED because there weren't
Mm-hmm.
beds in the hospital to move the
Mm-hmm.
patients out and get more patients into
Right.
ED. And so we had to work on our throughput, which is getting
Mm.
patients from the ED and admitted to clean beds with staff available to take care of them. So that
Yeah.
another big issue that we had to deal with.
Yeah, that's such a good point about changing overall systems and how one issue that needs addressed through quality improvement has a ripple effect oftentimes to other
Absolutely.
areas. Yeah,
Yeah.
that's a great point. So um, in this particular case, and you might have highlighted this a little bit, but can you talk about how the role that nurses played in identifying the system issue versus individual errors? So sometimes in the role that the nurses have at the bedside, wherever they may be, they may identify system issues, and it's not so much about one person doing something wrong or even one unit maybe doing something wrong, but it's system wide. So what role do nurses play in identifying those issues?
I think it's really important for nurses to be aware of the data.
Mm,
You will have access or have availability of certain amounts, certain types of data
mm-hmm,
in your work as an RN. So there's one of the things I know we're going to talk about this a little bit more, but the nursing quality indicators.
mm-hmm,
What can nurses influence? So, for instance, it seems to be that you're having a lot of falls on your unit, there's probably some data that's telling you this unit has more falls than other units. What
right.
can you do about this? And so those are areas that nurses need to say, hey, this is a perfect opportunity for us to look at what we can do to improve and reduce the rate of falls.
Mm-hmm,
And in quality improvement, I can't emphasize this enough. You always start out with your outcome in mind. What is it you want to achieve? So if you say we have to reduce the amount of falls,
mm-hmm.
or actually I would say not reduce the amount of falls, I would say completely prevent falls.
Sure.
Yeah. So you have that outcome in mind, and then you work with your team. And again, as Dr. Wise pointed out, it's going to be an interprofessional team, most likely. to identify lots of ways. What can you do to reduce falls? This
Mm-hmm.
also gets into, I know you learn or you're learning about evidence-based practice.
Mm-hmm.
There's a lot of evidence and guidelines for reducing falls. How do you prevent falls in a hospital or a long-term care setting, or even in a clinic setting?
Mm-hmm.
And that's where you need to look at your evidence, what's been done that works, and then how do we do what we need to do that fits our facility or our unit.
Gotcha. That's great. And I think it's important to focus on that evidence is very objective, and that data really, that objective data can really inform, what direction we want to go and provide a form of measure to see if the outcome has changed, right? Or if we're continuing to have the same issues happen.
Yeah.
Um, all right. So, quality improvement standards, and like you mentioned, we're going to lead into talking a little bit about external standards that might guide our quality improvement efforts. So, there are organizations, there are groups who set external standards that hospitals adopt voluntarily or not in order to show that they are safe quality environments. And so these are things like National Database of Nursing Quality Indicators, Joint Commission, core measures, leapfrog. There's actually many more, but those are a few examples. So tell us a little bit about how these standards are used in practice to shape quality improvement initiatives and improve outcomes.
Okay, thank you. That's a great question. So I'll start with NDNQI, the National Database of Nursing Quality Indicators. Though that is, many hospitals participate in the NDNQI survey system. And it basically provides you data. It doesn't tell you how to make anything better, but it's going to tell you where are we with several things that nurses can directly impact. Some of them are patient related, like nosocomial infections, CODIs, falls. Some of them are actually work environment related, like you can get nurse turnover as part of the NDNQI. So you use those data points for QI to say, oh, we're really having a problem with nursing turnover on this unit. Is it just our unit? Is it across the hospital? What's going on? Or it could be a clinical issue such as CODIs, catheter-associated urinary tract infections. Do we have a higher rate of CODIs than the national average? Because the NDNQI data compares your data with nationwide, or it may be more local, but not all hospitals have that, but they do. Then your core measures are required by Medicare. And again, those are quality indicators for things that you're doing for, like stroke. If patients come in with a stroke, with a myocardial infarction, whatever, then there's certain things you should be doing. And those core measures, if you're not collecting them or you're not seeing that you're getting those accomplished, those are opportunities to have a quality improvement initiative to improve that. But all those national initiatives just give you the data points you need to we call it benchmarking, to say this is where we are, this is where compared to other places, so we can do a lot better. Or maybe you're doing really well on certain areas. So, and one thing when you do look at that data, you do need to prioritize. You cannot fix everything. You cannot do everything. So you've got to think, what are one or two most important quality improvement initiatives we need to have going on for the next 6 months or so. So because you still have there's still so much. You'll be so busy doing things.
Mm-hmm.
But prioritize your quality improvement initiatives and then look at that data, and that will help you know what your outcomes need to be.
Gotcha. That makes plenty of sense. And likely we're going to prioritize those initiatives based on maybe what is, causing the most harm, or, what even sometimes too, what's the most costly thing, because the bottom line sometimes is the financial aspect of things. But there's various, what would you say, how would you prioritize where you're going to start when there's multiple areas that need some attention?
I think I would prioritize the one for me. It's all about the patient's
Mm-hmm.
quality of care. So I would prioritize what can we do to improve care for our patients. My second priority would be the nursing staff. What can
Mm-hmm.
we do to make a healthier work environment for our nursing staff? Because there are lots of things. There are many things you can work on to change if you feel like your environment you dread coming to work, you're not getting the support
Right.
you need, that just whatever it might be. If you can talk about this openly with your managers and your team, there's ways that you can address those areas.
Yeah, exactly. And once again, when we talk about the trickle down or the ripple effect, I mean, if the nurses are not looking forward to coming to work or they choose not to show up or they're not, happy and satisfied, their patient care is probably not going to be to the quality that it could be too. So,
Right.
yeah, that absolutely has some additional influence. So, all right.
Definitely.
So let's kind of shift gears a little bit to talking about a quality improvement culture. So, when you think about an organization, what does a strong QI culture look like from your perspective? And what are some key components that make that culture work in the clinical setting?
Okay, that is such a great question. And I hope you all will take this with you when you look for a new job, because these are great questions to ask about the work environment around quality improvement. Because you want to be in an organization that does have a strong QI culture and really
Mm-hmm.
supports quality improvement. And some of the things to look for, first of all, there should be we call it a blame-free environment, that if you make an error, and believe me, I made many, many errors in my career as a nurse, and I know I caused patients harm. But I would always have a lot of support, because in the end, it would turn out it wasn't just me making an error. There were a lot of systems issues around, either short staffing, we didn't have the right equipment, medications that looked alike were placed on the same counter together or
Mm-hmm.
whatever. Now I know they come out of a Pyxis, but before we just had medication stocked in a cabinet. Um, so there were so many systems issues that can impact the errors that are made. So as long as your leaders, the leadership of the organization is willing to look at the systems issues that could have caused errors, where do we need to improve the quality? Another thing to look for a QI culture is their training and support for quality improvement initiatives. Do nurses get time to spend on a quality improvement committee? Because it takes time. We don't, it just doesn't magically happen while you're taking care of six patients. You have to have time to sit down with a team and talk about how you can make some improvements. And so is everybody trained? Is everybody on board and accepting of new suggestions and new
Mm-hmm.
ideas? So that's a good thing to ask. If I have an idea for quality improvement, if I see some issue that I think we could address through QI, or would you be open to that? So I think looking at the QI training, openness to new ideas and new initiatives, giving time for quality improvement, and then the blame-free environment. I think those are some key components of a good QI culture.
Yeah, I like that a lot. And I like your suggestion. I was thinking about, as students are applying for jobs and they always ask you that, do you have any questions for us question? And sometimes you're
Yes,
freeze up.
yes,
What a great question to put on your list.
it is. Yes, have
what
this.
is,
What is your
yeah,
QI culture?
yeah,
Yeah,
exactly.
how do you train us to do quality? How do you give us time to do quality improvement? What's your support for quality
Right,
improvement? Yeah,
right. I like that. Very
great
good.
question.
So, what advice do you have for students or new nurses when they're in environments that don't quite walk the talk when it comes to quality? What can be done to contribute to improvement at their level and maybe influence change from where they are in that new graduate nurse or even just a staff nurse role?
This this is really tough if you don't have the organizational support.
Mm-hmm.
Because when you have the organizational support, it makes it really easy to do QI. But when you don't have that, if people just, this is the way we do it, we're not changing, then it becomes difficult. So some of my suggestions is to get a group of champions, maybe a group of 2 or 3 or 4 nurses that see the same issue and find a supportive, receptive leader. Either it might be a charge nurse, a director, a physician. I know at one time we had a major issue when my first several years in nursing was in critical care. And so we had some pretty big issues we needed to address. We couldn't get the nursing leadership to work with us. So we went to the physicians and said, hey, we think that we could take better care of your patients if we did these things, if we tried some new initiatives. And the physicians really went to bat for us. They got
Oh,
on
wow.
where they talked to the nursing leadership, and we knew who had the power in that particular hospital. The physicians had the power.
Mm-hmm.
And so nursing leadership then got on board with us as staff nurses, and we were able to make some really good changes in our critical care unit. So you just have to, don't give up. Know that there's, at some point, there's always a way, but you've got to find the right people and the right champions. Figure out who has the power to make some change that will
Mm-hmm.
support you.
Yeah, that's great. What a great example. And we all have influence, and likely if you see something concerning enough, you can bring your evidence to support your concern. Even ideas; those are all ways to help build your case for getting that buy-in to influence some change. So, great example and great ideas.
And your comment using evidence, always have
Mm,
data. You need data to say, data speaks
right,
loudly. So
right.
have data that says this is the issue, and here's the data we have that shows that we have high turnover, or we have um, you know, high fall rates, high
Hmm.
infection rate, whatever it is,
Yeah,
have your data.
exactly.
Yeah,
I always like to say, in my less formal way, I have to simplify things for myself, but you can't argue with the facts, right? If you bring facts,
exactly. Exactly.
then
Bring facts.
you gotta
Yeah.
it supports your perspective and
Yeah.
and what you're trying to do. So, okay, so let's look a little bit or talk a little bit about tools and models. I know that in the resources there's some different types of models that are used in a change process and quality improvement. So, some of the ones that students might see in their text or may have heard about or been exposed to are the PDSA cycles, root cause analysis, failure mode and effect analysis. There's a few others, but those are ones I would say most often used. So, explain a little bit about what these are, I guess, and if you have some examples that might help to be able to apply what these change cycles or processes might look like.
Okay. So PDSA is actually Plan, Do, Study, Act,
Mm-hmm.
and it is actually the process you follow to implement a quality improvement initiative. And so your first question in the PDSA cycle is, what do we want to accomplish? So that's what I was talking about. Know your outcome.
Right.
What do we want to accomplish? We want to reduce falls in our nursing home. Um, then you have to set out a plan. Who's going to be on our team? Who are our leadership support people? You always have to have that leadership support to make changes. Where's the evidence for reducing falls? What can we do to make a change? And then so you come up with your whole plan, and then D is the do. We
Mm-hmm.
actually implement that plan. And then S is study, and we see how we follow the data. Did
Mm-hmm.
we make an improvement? Oh, and typically in your plan stage, you're also going to have a plan for education. So you're
Mm-hmm.
going to have a smaller team that's coming up with these ideas, but you definitely have to educate the rest of the staff about what it is you're doing and get their buy-in.
Mm-hmm.
Um, and then act is, if it worked, if this was a really good change that you made, then you work on how do you, we call it institute, or I call it institutionalize it. Do we need new
Mm-hmm.
policies? How do we make this process stick? So
Right.
from now on, we're doing this because we really had great success in reducing falls. So that's your actual QI process. And there's another one. Most hospitals either use the PDSA cycle process or they use Lean or Six Sigma. And so,
Yes.
and I won't go into Six Sigma because it would take too long, but it is in your materials. But those wherever you go to work, and that might be another good question to ask, is what model do you use for quality improvement?
Mm-hmm.
Most systems and organizations either use PDSA or Six Sigma for their
Gotcha.
quality improvement processes. The
Great.
failure mode effects analysis, FEMA, we call it FEMA.
Mm-hmm.
That's typically we do those if we're going to start a new process or a new program. We look at what could go wrong. So it's
Mm-hmm.
really looking at it in it before you start the new process. You're trying to look what could go wrong with this new process that we're starting. Say you have a whole new process for running your IV pumps or training
Mm-hmm.
or whatever, but you've got to say what can go wrong here, what's going to happen. And so that's where you're looking what can fail, is why it says failure mode.
Mm-hmm.
What can fail and what's the extent of that, the danger of that failure. Is it very high or is it just a minimal chance that this could happen? There's actually, if you Google FEMA, you'll find some toolkits or a spreadsheet where it shows you how to analyze a process
Mm-hmm.
and then how to rank it and say this is very likely to cause great harm or very unlikely. And from there, you either make changes to your process or, you may not even want to do it because you've identified this could cause some serious harm. So,
Right.
and then the root cause analysis, you're going to use that when something bad has happened. You've had
Mm-hmm.
a unexpected death, you've had a bad fall, you've had even a crisis with a staff member, say
Mm-hmm.
they've been involved in a violent event with a patient, workplace violence, or with another staff person. And so you can do a root cause analysis to really analyze that situation, figure out what went wrong and what can we do better.
Mm-hmm.
So those tools are wonderful, wonderful tools. You need to know them. You will be using them in the workplace. They are frequently used. And so it's kind of dry reading in your textbook, but when you apply it to knowing that this really impacts what's happening in the real work world, they make a difference to understand what those tools are.
Yeah, that's great. Uh, Here's a quality improvement idea. Maybe we can make the reading less dry and more enjoyable.
Yes,
But
yes,
no, those are. I appreciate the explanation because it kind of it makes it a little bit more. I don't know, simple and applicable to understand what each of those different processes are, and also when we might use them too. Because
right,
like you said, a root cause analysis. That's when we have had something that we actually have to go figure out what was the root cause to this problem
right.
happening, right? So and I think as with many things, I kind of mentioned the similarity to the nursing process. Using some type of structure or framework gives more intentionality or plan to what you're going to do, to where you're taking the right steps, you're not missing some part of the process, and then going back to data, we can measure what's actually changed and have a change that is impactful and
Yeah,
long standing. So,
yeah.
um, so which of these tools, I don't know if it could be all of them, I suppose, but from your experience, which of these are used most effectively in practice, do you think?
I think the root cause analysis and then, of course, the quality improvement processes, the
Mm-hmm.
PDSA, the FEMA isn't used as often, but root cause analysis. And in fact, I just need to tell this little story. Y'all may have heard about Rhonda Vaught. I
Mm-hmm.
think
Yes.
she was a nurse in Tennessee who was criminally charged, which meant she could go to prison for
Mm-hmm.
a medication error. And if you Google her name which I can't remember exactly how to spell her last name, but
Mhm.
it's Tiffany. Dr. Wise might know.
Yeah,
But
it was it
anyway,
like Bought, maybe?
yeah,
Something like
and
that.
she was working at Vanderbilt in
Hmm.
Tennessee. And she made a very serious medication error. And then, like I say, she was criminally charged. But when they did the root cause analysis, there were so many issues that happened about how the medications were stored, how two medications looked very similar, how
Hmm.
the environment was very rushed. The patient was very, very agitated. I mean, there was just so many things that contributed to this error. It
Hmm.
wasn't just, oh man, she really messed up and she needs to be put in prison. She didn't. She got probation, which we were all so glad she didn't have to go to prison because she had
Right.
a lot of support from nurses
Hmm.
and the nursing organizations. But that the root cause analysis was used to determine how many other things played into this error that happened.
Yeah, well, that's a great example. And yeah, I do encourage for, the students listening, if you haven't read about that case, definitely Google it and read about it. I mean, there's so many lessons learned and implications around that. But it is, I mean, it's very unfortunate the impact it had on the patient and the
Yeah,
family.
it's a big,
However, I mean, a picture perfect story of systems issues, one after another, after another, after another, leading to a life-threatening error. And it all could have been avoided through
yeah,
those systems errors being corrected. So great example.
yeah.
Um, okay, so taking this back a little bit, not looking at it such a big picture standpoint, one area I think where this can be a struggle for a student or a new nurse is to think about how these tools apply to their day-to-day work. So how would you describe an application of that just in the day to day, working at the bedside, in that new nurse role?
I think probably, understand as a new nurse in an organization what their QI process is. How open are they to new ideas? And then when you see things that are a little bit frustrating, or you feel like, oh no, my patient fell, it was all my fault. I had a medication error, or my patients are getting cauties. You need to think there's something more to this than just, it's not just me. There are some system issues besides what's going on here. I mean,
Mm-hmm.
you do have to, accept full responsibility for the care you provide the patients.
Right.
But there are systems issues that really interfere. I mean, after 50 years of nursing, um, I've had patients die because of errors, and they were my patients, and I was taking care of them. But I had to recognize, in order to kind of get through that and continue being a nurse, that there were so many contributing factors at the systems level. So,
Mm-hmm.
no, you're not working in isolation as a new nurse. There's a lot going on, and you need support from your managers, your colleagues, your interprofessional team, pharmacists, physicians, whoever. But do try, when you do see things that you feel like need to be improved, try to bring those up, talk about
Mm-hmm.
them, and see what kind of reception you get.
Yeah, that's great advice. And I also think about too, I think students notice, they learn how to do something in the simulation center, or, certain skills or processes. And then they go to clinical and they see shortcuts taken, or
Right.
other things that are done. So I think about too, like if you find yourself having to take X shortcut every time you're doing a certain process, maybe you need to ask yourself why. Like, is it because I'm trying to cut the corner, or there's a system problem here? And I think that's part of that, taking ownership, right? Ownership over your responsibilities,
Yes.
um, doing practice, to the highest standard. But if we're doing practice to the highest standard and we still notice we're making shortcuts or doing something different, that is a prime opportunity to ask yourself why. and see if there is a systems thing or quality improvement that might
Absolutely.
be behind
Yeah.
that. So yeah.
Yeah. Looking at always think about the systems. You're not in isolation. There is a huge system that's contributed to your ability to provide care to a patient.
Right. Yeah. Very good. Okay, so this is going to kind of change gears a little bit, but I want to talk a little bit because it's very closely related to quality improvement about resource management and cost-effective care. So when we review in our materials, there's emphasis on the fact that quality care isn't just about outcomes, but it's also about using our resources wisely. And that does kind of go back to I kind of threw in there earlier about the financial aspect of care. It is a thing. So how do we as nurses contribute to cost-effective care while still protecting patient safety and quality?
Well, those are completely intimately tied together, the financial piece and the care quality.
Mm-hmm.
So one example is patient falls. If a patient falls in the hospital and they have to stay a couple of days extra in the
Mm-hmm.
hospital cannot bill Medicare or the patient's insurance company for those 2 extra days of care. So the hospital loses money when there's an error like that, like a patient fall, and there's a specific list of errors that will not be paid for.
Mm-hmm.
Falls, infections that a patient gets while they're in the hospital.
Mm-hmm.
And these are nursing things that we can make better. So that's a key is just the reimbursement to the hospital saves them a lot of money. The other thing, hospitals do look at supply usage. So there may be a lot of quality improvement. I've seen several of my doctoral students do quality improvement initiatives in the operating room around the use of supplies because they use so many different kinds of supplies in the operating
Mm-hmm.
room. And how do they have a more standard? Every surgeon wants their own specific type of equipment and sponges, and it's very expensive to maintain all that inventory.
Mm-hmm.
And so when they got everybody on the same page, they saved hundreds of thousands of dollars in supplies for the hospital. Another one I know when we did the project on reducing left without being seen in the emergency department,
Mm-hmm.
the one thing we didn't plan on that was like a very positive consequence after was one day the chief financial officer said, "Hey, guys, this is great because the way I look at those left without being seen patients is that's money walking out the door
Right.
because we can't bill for that." And because the patients, when they come in, they're immediately registered and then they just sit in the waiting room. So they
Mm-hmm.
had all their insurance information and they knew that this was a potential for the hospital to bill for this care that the patient needed. But when they left, they didn't get to bill. So they actually, the financial people looked at it as money walking out the door.
Right.
And so we started analyzing that when we improved our left without being seen with the help of the finance people. And we were saving, I mean, we were bringing in about almost $1 million more to the
Wow.
hospital. And also, you developed loyalty with those patients.
Mm-hmm.
So they come back to this same hospital system because this is where they got good care. They got good care in the emergency department, and
Mm-hmm.
it creates a loyal patient. So
Yeah.
almost every project you do is going to have a financial implication.
Right.
Nurse turnover. If you can do things to improve a healthy work environment, create joy in the workplace, nurses want to come to work. It it costs around there's lots of different numbers that float around there, but around $60,000 to replace a nurse. By the time you go through the hiring, the training, the time they're not productive because they can't take a full load of patients until they are get used to the system and are trained.
Mm-hmm.
So everything you do has a financial component. And you can always be aware of that. And the finance people, that's another group on your interdisciplinary team that you need to remember to think about is what's
Mm-hmm.
the financial implication and how can we get support from finance to help move this project forward.
Yeah, those are great examples. And sometimes it's a matter of we need to save some money. Sometimes in your great example that you gave, it's we could be bringing in more
Bring
money.
more
Like
money. We're
we're
bringing,
losing money
yeah,
here. Yeah.
which we don't think about. We want to bring people into the hospital, but if they
Right.
need care, they need care, and you want to get them there.
Yeah. And it's a fine line too. I mean, we don't want the financial aspect of things to be the number one focus because then we
Exactly,
might compromise
exactly.
quality, right? But it is an important aspect that must be considered. So
Absolutely.
awesome. So you mentioned a few things, but when we look in a practical sense, resource management, it might include staff. You talked about nurse turnover, and different staff's going to have different cost implications because, I think when we think of a hospital, you think about the physicians and nurses, but you have all your ancillary care too. That's an aspect of it. There's supplies, there's time. Time has a number associated with it.
Absolutely.
So, what you did give an example, like you said, in your left without being seen example. Do you have any other examples that you would want to share about when thoughtful resource management improved outcomes or prevented a safety issue?
Yes. So, in 50 years, you get a lot of experience.
Yes, I think so.
Um, so, I think the thing that I always, because most of my career, I have been in management, leadership and management position
Mm-hmm.
or in academics. But the number one thing that I know is that staffing is the most expensive item on a hospital budget, a nursing home, whatever facility, staffing is costing the most.
Mm-hmm.
So if you want to save the most money and have the most impact and also improve care at the same time, you've got to look at what are the nurses doing. And so at one point in my career, I had my staff, all my nursing staff, make a list of everything they did every day. Just jot it down, keep a record. And when we looked, probably 40% of what they did not require an RN license.
Mm-hmm.
We could have other staff to do these various chores that came up or tasks or whatever they
Mm-hmm.
were. It didn't impact quality, and we were able to actually reduce our staffing. We didn't do it. We didn't like lay off people, but through attrition, we
Mm-hmm.
replaced some patient care technicians instead of hiring RNs, and that helped save money. But the other thing, there's a pretty strong movement now in many healthcare systems to have a team model of care where
Mm-hmm.
you have a nurse working with an LVN and maybe a patient care technician. And so the nurse is working, we call it top of license. You are doing everything that you do as a registered nurse. But the things that you can delegate that do not take an RN license to do, then you delegate those to the LVN or the patient care technician, whatever other help you have there, and let them do those things, but you're still very responsible for that safety and quality of patient care as the
Mm-hmm.
registered nurse. You've got that top of mind, but you're directing these people, you're with them, you're a team, and it's proven to be pretty successful, and it can save a lot of money because again, the RN is the most expensive because they're the most, number one, they have most RNs in the hospitals, and then they also have there's more of them, and it's just the labor is the most expensive
Right.
item on a hospital budget, and that's where the finance people are going to look to cut
Right.
if they want to make cuts. But we can do it as nurses and preserve that focus on quality and safety.
Yeah, that's such a great example. And I mean, that is going to also impact when you talk about a healthy work environment. When I think there's been a lot of concern about the total patient care approach for
Yeah,
RNs because they just can't do it all. And then
right.
then you start talking about staffing ratios and it leads down a whole nother issue.
Exactly.
And so yeah, this I think, and you can help me because you have more history and context than I do in my experience, but I think we used to use more of a team approach in the past, and we moved to
We
this,
did.
right. And we
Yeah.
moved to this total patient care model. And now we're finding the value in maybe we need to go back to what we did before.
Yeah. I
Yes.
mean, I can remember coming to work. If I didn't have my nurse aide there, I was like, oh my gosh, because the nurse aides could do so much to help.
Mm-hmm.
And I could really focus on what was important for
Yeah.
the patient.
Yeah. I think too, just thinking about context and timing, a lot came to light in and after COVID in that period,
Yeah. Uh-huh.
that about the issues around staffing, because we got pushed to a point where it had to be fixed and we had to start thinking
Right.
about
We
things
had to fix it
differently.
fast. We
Yes,
had to do it
exactly.
fast. Yeah.
Yeah. Awesome. What a great example. So I think, we've touched on many key parts of quality improvement. It's been a wonderful conversation. We talked about what it really means, seeing it in practice, the role that we play in systems level change, which is a very influential role. And then also strategies for creating a strong culture environment through resource management or our personal ownership of being involved in that quality improvement process. So great. So one of the things that I promise students in doing these interviews and conversations, is that I will help with how this shows up on exams, because at the end of the day, we know they want to pass their
They want
exams.
to pass their exams. I'm
Yeah,
with you.
that's a
I
little
agree.
right. That's maybe,
I've
I
been
don't
in
know. They
school enough that I know I want to pass my exam.
right, exactly. So if you don't mind, would you go through about three practice questions with me that are all around quality improvement to see if we can identify the correct answer and talk a little bit about, how this is showing up in exam questions?
Oh, yes. I
Awesome.
hope I get them right.
I bet you
I
will.
hope
I
I
bet
can
you
answer them.
will. I know. And so for those listening, my guest has not seen the question, so it's kind of cruel
No.
of me, but that's okay. I know you're going to do great with these. So let me share my screen here. All right. Can you see those okay?
Yes.
Okay. So question number one, I'm going to read the question and read the answers in case we have somebody just listening and not watching. And then we'll see if we can find the right answer. We'll talk through the
Okay.
rationale, and we'll do this 3 times. So, all right. So the nursing unit has implemented a quality improvement program to improve client pain management. Which of the following indicators is best for measuring quality improvement? So, option number one, better client pain control as reported by a survey of the unit's nurses, improved client self reported pain scores on medical record audits, increase in frequency of PRN analgesics administered to clients, or increase in positive feedback on client satisfaction surveys. So we can talk through it. You can give me an idea of what you think. Where would you lean towards on this one?
Okay. Well, I'll tell you one thing about quality improvement. I don't think I brought out. One of your main focuses on quality improvement and your outcomes is your customer, whether that customer is another nurse, your nursing unit, physicians, or most of our customers would be our patients.
Right.
So, with that principle of quality improvement in mind, I would answer B for
Okay.
this question, that improved clients, patients, self-reported pain scores. If they're showing improvement, then we know, it's coming directly from the patient. The
Right.
nurses can't really judge the pain so much. So A is definitely out.
Right.
That's not a focus on your customer. I think C doesn't get enough good data in there. And if you increase the frequency of PRN analgesics, that means your pain is getting, I would say, worse, not better.
Sure.
That one
Sure.
makes sense. Um, you would have an increase in positive feedback on client satisfaction surveys if your patients have a better experience with their pain management. However, they may have a better experience with many things that influence that positive feedback. So
Right.
you wouldn't know for sure if it directly impacted pain management. So my answer is B,
Very
improve
good.
client self-reported pain scores. Did I get it right?
Oh, hold on. Next slide. Yes, you did.
All right.
And I
Yay.
appreciate you explaining your thought process behind that too. I think that's really important. So great job.
Thank you.
When I like the perspective. Another big thing when you think about, rationale behind this and processing through it, we don't want to rely on we want to rely on objective data, right? And so if we go back and we look at, like you said, the client self-reported scores, that is directly from the client, right? And as well, it's objective data. So we can use that to support, like you said, the survey of nurses. That's subjective, and they can't determine what pain somebody's in, right? Um, use of frequency and use of PRN analgesics. I mean, it could be attributed to let's see here, many factors, right? It doesn't necessarily mean pain management is better. And um and I also think about too, that's not a direct correlation to the pain management itself. And then also for D, the positive commentary, once again, it could be related to all aspects of care, not just the pain management. So great job. So the objective we want to see out of this one, is that quality improvement programs use a measurement method and are client centered, and that they're objective or quantifiable. So great job. Okay.
Okay.
So it's not too bad, right?
Okay, one
Okay.
down.
One
I'm
down. All right.
good
Moving
here.
moving into number 2. All right. So the question is, which issue would a unit quality improvement committee address? Is it a 10% decrease in client satisfaction in the registration process? Or B, a nurse who made 3 medication errors in the past quarter? Or C, an increase in catheter associated urinary tract infections? Or D, staff perception of hospital laboratory personnel incivility?
Okay, so if I'm assuming when it says which issue would I would assume this is a nursing unit.
Right.
So on A, we don't really have any control over the registration process.
Mm-hmm.
I think we might want to talk to them and say, hey, our patients are getting up here and they're not happy with your registration process, but we
Right.
can't control what they do. So
Mm-hmm.
A is out.
Okay.
A nurse who made 3 medication errors in the past quarter. Um, if it's one nurse, I'm thinking on this one that this may be a personal issue with this nurse,
Mm-hmm.
might need some corrective action with the nurse versus a whole quality improvement committee for one nurse who made an error.
Right.
So if there were multiple errors among multiple nurses, yes, that there's something going on more systematic. But this is a particular individual case, it looks like to me.
Mm-hmm.
So number C, an increase in catheter-associated urinary tract infections, that would definitely take a quality improvement committee because this is something that's happening across your unit. You've seen an increase in these infections. It's going to cost the hospital money. It's cost the patients possibly more days in the hospital. It's really not something you want to happen to your patients. They can have complications from those CAUTIs. So
Mm-hmm.
I would say the answer is C, because again, on D, staff perception of the hospital laboratory personnel incivility, that is a problem, but it would have to involve the hospital lab versus the unit QI committee.
Yeah.
So my final answer is C.
Okay. And that is
Oh,
correct. So yay, you're
right.
2 for 2. I don't know that I could explain the rationale any better. I think you hit the nail on the head with all of the answer choices and why they would be correct. When we look at, breaking down the question, it's so important to pay attention. In the question, it says a unit quality improvement, right? And that's like you said, like the
Right.
nursing
Yes.
unit.
Yes.
These are all opportunities for improvement. But when we're looking at this particular question, we need something that is unit specific. And yes, you explained each one of them perfectly. So
Thank you.
let's see here. And in this case, too, we're looking at systems, we're looking at standards, we're looking at, changes across the board that influence whatever group it is that we're looking at. So, and like I think you might have mentioned, CAUTI or catheter associated urinary tract infections. These are one of those major like core measures and quality indicators, and also have that financial implication that if we cause this in a patient, there is no payment back to the hospital for that, because
Right.
we're supposed to be in the business of making people better and not worse. So,
Absolutely.
yes. All right. Last one. I feel really good about this.
Okay.
Okay. The question is, a nursing unit implements a quality improvement process of written reminders to improve incentive spirometer use in a post-operative clients. What is the best indicator that the client goal for this process has been met? So, would it be A, chart audits indicate that client incidence of nosocomial pneumonia decreased by 20%? B, documentation shows that 100% of nurses attended an in-service seminar on the topic. C, nurses report an increased number of written reminders given to appropriate clients. Or D, surgeons who admit to the unit, surgeons who admit to the unit report increased satisfaction with current client incentive spirometer use.
Okay. So I'll just go through these like I did the others.
Okay.
Also, now, and I want to explain one thing that some of the materials that you have to review, they talk about process and outcome measures.
Mm-hmm.
And when you're looking at anything with quality improvement, and this question's asking you the best indicator of the goal, which
Mm-hmm.
is the outcome for the patient. So, number one, chart audits indicate that a client incidence of nosocomial pneumonia decreased by 20%. That is definitely client centered. That the purpose of IS, the reason we do that incentive spirometer, is to prevent pneumonia, nosocomial pneumonia. And so right now, until I read the other three and talk through them, my answer would be A, that
Mm-hmm.
our outcome is decreasing pneumonia
Okay.
through the improvement of use of IS for our patients. B, documentation shows that 100% of nurses attended an in-service. That's really a process measure.
Mm-hmm.
Oh, but just because nurses attend the in-service, that doesn't tell you if you've really achieved the outcome
Right.
of this quality improvement project. It's important. They need to attend the in-service, but it is not your outcome. It's just part of the process
Mm-hmm.
to get there. Number C, nurses report an increased number of written reminders given to appropriate clients. Again, this is process.
Mm-hmm.
This is a process measure. This is good that they're reminding the patients or giving them written reminders, but we don't know for sure, did we really reduce nosocomial pneumonia because of these reminders?
Right.
And the last one, the surgeons who admit to the unit report increased satisfaction with current client ISUs. Same thing. We want the surgeons to be happy and to see that we're really trying, but the bottom line is, what is your outcome? And the outcome is that you have reduced nosocomial pneumonia by 20%. So final answer is A.
Okay. Let's see. Yay. You got it right. So,
Yay.
see, they weren't too bad. I
They
think
weren't too
that,
bad.
yeah.
Yay. I feel pretty good.
Yeah, good, good. Well, once again, your explanation to the answers that you selected was so helpful. I mean, and thank you for pointing out that difference between process and outcome, because there are certain processes that need to be implemented. Yes, we need to see that nurses are attending the in-service so that they understand that the education piece you talked about earlier, but we need that actual data that shows the change. And for students, I want to point out on this one, when you are taking your exams, your NCLEX related to topics in leadership and management, you're going to see that your questions are not necessarily going to say, like, what is a quality improvement? What is PDSA? It's not going to ask you that. It's going to give you a scenario. Likely, you're going to need to pull on some previous knowledge, like the fact that incentive spirometry postoperatively is going to help to prevent nosocomial pneumonia, right? It's going to prevent those implications. So you're going to pull from some of that previous knowledge in the context of your understanding of in this case, quality improvement. So I think this is a great example of what questions can look like when you're pulling information together, but to identify a quality improvement principle. So awesome. Great job. So let me stop sharing my screen here. Awesome. So
That
I
was
guess
fun.
now you can breathe. No more pressure.
Yeah, that
Okay,
made me a
but
little nervous having to answer test questions.
I'm sure it did, but I appreciate you doing that for us. I think it's kind of
Thank
fun
you.
for the students to have
Mhm.
the experience with you doing it based on your knowledge. And thank you for letting me pop those on you without giving you
Thank
them
you.
beforehand. So, okay, last question for you that I like to ask everybody that I talk to, because I get such valuable answers. So, what is the best advice that you've ever been given?
Okay, and this comes. I've got a good one. I'm actually going to read it from a chapter that I wrote, but it comes from my vision as an educator for
Mm-hmm.
students. So, and it says that every nurse should enter practice accepting accountability for the quality of care provided by the healthcare organization and taking a leadership role to implement improvements to achieve healthcare that is safe, timely, effective, efficient, equitable, and patient-centered.
That's
So
awesome.
that just we have to prepare nurses. What you're doing, Dr. Wise, is amazing because nurses have to be prepared to do quality improvement. And that is one of the missions I live by for my role as an educator.
That's so good. Thank you for sharing that with us. And I think there's
Thank
so
you.
much truth to what you have to say. I mean, it's the quality improvement focus and approach should just be foundational to everything that we're doing because,
It should be,
you know,
absolutely.
I say it in a very simple way. And I tell my students this when I was in the clinical setting with them that, you know, we want to leave our patients better than we found them when we got there. Even if all that was that we gave them a smile and encouragement, or we did something really impactful. But that's all through implementing the best standards of care, using quality improvement, and making sure that everything we do is making our patients better. So that's a great piece of advice.
Thank you.
So thank you so much for joining me today. The
You're
insights that you gave
welcome.
us, yeah, they helped to make what you said was dry in the text, which I would agree, feel very practical, purposeful, and most importantly, doable. I think for stepping into practice, especially for our students. From continuous improvement to systems thinking, like at standards, resource management, you did a good job of helping us to connect the dots on those things and especially moving it from theory to real world application. So, for the students listening, I hope this helps you wrap your head around what quality improvement means. Remember that QI is not just about charts or data or policies, certain departments, but really it's about the decisions that you make every day that impact safety and outcomes and the team that you work with. So,
Yeah.
as you move forward, remember that we are change agents as nurses. We drive change. Our role in quality improvement starts the moment we start asking questions, noticing patterns, thinking critically about the care that we're providing. You don't have to have a title to make a difference. You just need to be aware, take action, and have a commitment to always be learning. So, we'll continue to build on these ideas. And yes, they will show up on your exams. So pay attention. But most importantly, let it influence the kind of nurse that you want to become. So thank you for tuning in to this episode of Leadership Chats with Dr. Wise. And until next time, keep learning, keep leading, and stay curious. Thank you.
Thank you.